Thank you so much, Jennifer. Good morning. I'm gonna try that again because I know it's 11:15 and I'm asking a lot from you guys. Good morning. Thank you guys. Thank you so much. I want to thank Mary Claire Clark, who is one of the members of the Maternal Mortality Review Committee that I serve with here in the state of Indiana. I serve proudly on this committee, representing as many and as much as I can, whatever I can bring to this committee. And she curbsided me a couple months ago, and she was like, "Dr. Hawkins, are you free May 1st?" And I was like, no. But I'm so glad she gave me the opportunity to come to you ladies, so thank you so much. Jennifer has been amazing. I am not an easy speaker to work with, so I thank you for your patience with me. And they tell me I'm the only thing standing between you ladies and lunch. Okay, let's get through these slides. So first of all, the title of my talk is We Are Family. Obviously, that reference does have a little cultural meaning from the 1970s. I know you all know Sister Sledge, but my talk will be kind of focused around Black maternal health and the roles that I feel like we all play. There may be some content in my lecture that may be hard to hear. I heard the previous speaker say, just breathe. Some of the things I want to talk about are uncomfortable. Some of the things I want to talk about may make you kind of squirm in your seat just a little bit, but it isn't intended to cause any hard feelings. It's to open eyes and to open hearts, really. That's my goal for coming today. Boo me if you want to. I don't care. I'm going to keep talking. But I really am excited about being here. This is my first official trip to Fort Wayne, although I have some Fort Wayne connections, so y'all better treat me nice so I'll come back. And I worked, let's say, labored, trying to get this particular slide to work, so I'm gonna see if it'll work because I trust Jennifer and I know she's way better at this than I am. Thank you guys for indulging me. I worked so hard on that. I promise you like an entire day on Saturday. Okay. Oh, no, that's right. First, I want to talk about my financial disclosures. I am an equity investor in a company called Navigate Maternity. It does have ties, actually, to the Fort Wayne area. The founders, Ariana McGee and Dr. Alicia Harris, are both at the forefront of this company. We were talking a little bit about the Omnibus Act and how tech and technology have not been pulled in enough. This is actually a startup company working to create a platform, a software platform, so that providers can get real-time data about their patients. I'm gonna talk a whole lot about this later, but one of the things that we know about Black women is that hypertensive disease is one of the biggest thing that we are affected by, and because of that, we need to know what your blood pressures are kind of all times. You come to the office, sometimes you're in a rush, maybe it's a little high. You sat in the office for 15 minutes, then we took your blood pressure and it was normal. But this gives moms the opportunity to be able to get us that data so that we can act accordingly. We do know, like I said, sitting on the Maternal Mortality Review Committee, there are moms with blood pressures that are out of range and that need to be managed, but because it doesn't get directly to the provider, there's a delay in that communication. It does affect how these moms are cared for, and so they end up in our committee. So this is kind of a put your money where your mouth is, Dr. Hawkins, opportunity for me, but I do have to disclose that. However, it really doesn't have any influence on any of the research that I'm about to present today. Next, I want to talk a little bit about my objectives. The information that I present for you today will be kind of very basic level. I don't plan to get too deep into the weeds talking about Black maternal mortality. We are going to review some of the common sources of interference, as I like to call it, that some of our moms may express to us with what makes it difficult for them to be cared for in certain settings. I want to describe for you something called the weathering hypothesis. This was first introduced to me probably in the last 5 to 7 years, and I've been practicing medicine now for 20 years. But I do think it's a valuable tool to understand, to maybe explain why our Black maternal health rates are where they are. We're going to discuss the role of the healthcare team, and that's everybody. I'm starting with the patient and family because they're not to be ignored or left out, and I'm going all the way up to our state and federal level governments, because every single rung in that ladder has a role, and if anybody gets left out or forgotten, that's where we have these discrepancies and disparities. We'll talk a little bit about maternal mental health, as this is the reason that we all came today. And I want to actually kind of challenge you all to kind of look for ways within your own practice or within your own communities that you can bring in more awareness about maternal mental health. We don't have enough places for our moms to be cared for adequately, and we really do need to reach out, get our tentacles out there, and find ways to get these moms the care that they so richly deserve. We'll talk a little bit about some perceived celebrity experiences. You know, we talk a lot about Black moms in the media. Kira Johnson is an excellent example of what happens. I actually got to hear her husband speak at a meeting in Washington, D.C., and when I tell you the reason she got choked up is because his presentation is so impactful. He gave a minute by hour description of what their family agonized through in that 10 hours, watching his wife essentially die right before his eyes. It isn't something that you can sort of forget after feeling it and hearing it. As a healthcare provider, I'll be perfectly honest, I was ashamed at the care that she received at one of our greatest hospitals. Cedars-Sinai is definitely cutting edge. They're doing all the things right, but this woman did not get the care she deserved. So I totally understand her emotion in that moment, because, like I said, he gives a moving presentation. And then last but certainly not least, I just wanted to identify what some data has proven to show has caused racial disparities, because sometimes it's easy to think it or assume it, but when people have done the research and the bench work and the, what do you call those, surveys, we're able to show that there are actually disparities in how healthcare is being disseminated. And I'm going to try and focus on the maternal space, but I may kind of delve a little bit outside of that. Oh, there it is. This statement is a little hard to hear, but I'm going to say it, and when I say it, I want to pause a little bit to give you a chance to kind of receive it all. The most disrespected person in America is the Black woman. The most unprotected person in America is the Black woman. The most neglected person in America is the Black woman. By show of hands, has anyone heard that before? You've heard it before, so you know who said it. I don't know why my slides are skipping. Anyway, Malcolm X said this in 1962. 60 years ago, we were listening to our leaders try and tell us, and I get it, Malcolm X is not on everybody's top 10 books read list, but we were listening to our leaders tell us that we need to take a closer look. This population of women, they're being ignored. He was talking to a group of supporters in Los Angeles. I'm going to take some time today and explain why I think all those three things, the disrespect, the unprotection, and the neglect, and how they have impacted the disparities that we currently see. Black maternal health data has for a while now been looked at nationally. The maternal mortality review committees were formed into law in 2018, but we've had data before then talking about where moms stand. We have known that women of color, so our Hispanic women, our Black women have an increased rate of complications, but now we're actually seeing that come to fruition to acknowledge that there is actually data that says the Black maternal death rate is far too high. I'll have a couple of slides with graphs. I want to talk a little more about that, but this slide specifically speaks to the national and the data specifically here for our state in Indiana. Black women are 3 times more likely to die from being pregnant. It doesn't mean anything until a young girl walks into your office. I'm always talking, so she done sat there for a little bit. So, but by the time you get in the room, she still has tears in her eyes. She's pregnant. It's her new OB visit, and she says in a weak voice sometimes, "Dr. Hawkins, I just don't want to die." You don't feel it until you hear that. I get women that come in, professional women in their 30s, and that last line tells you that we know that there is no socioeconomic status that saves us. There's no educational level as Black women that saves us. There's no income level as Black women that protects us from potentially being a maternal death. And so my heart goes out to these women. I was a geriatric mother. I had my baby at 32. So I felt a lot of that, that anxiety, that worry. Now, we didn't have the data then, and my son is 14, that we have now, but I'm still getting those women coming to me today. I was selfish. I chose my career first. I didn't want to have a child in medical school. I didn't want to have a child in residency. So once I got out of residency, it was like full-fledged, husband, where are you? Get over here. We got to have sex. So, you know, I have my son. My pregnancy was mostly smooth. I'm a doctor. I'm a horrible patient. So, you know, got to delivery day and everything went great. No hypertension, no diabetes, although I failed my glucola. And no need for a C-section. No postpartum hemorrhage following. I didn't develop any postpartum preeclampsia, which I am honestly surprised about, because at the time I was an obese Black woman who wasn't getting enough sleep and I was not taking care of myself. But I don't see that now. That has escalated. The majority of my patients have some sort of blood pressure issue. Most of the time it's minor and it's just an indication for delivery. Occasionally it's a major interference and it's causing me to have to readmit them to the hospital or manage them. The other day, and I need to move on, I'm talking too much, but the other day I had a patient I took care of, really nice lady. It was her 3rd baby. She was in her 40s. It was a surprise pregnancy by her ex-husband. Don't ask questions. And she was actually angry with me because I wanted to deliver her prematurely because her blood pressures were in the 180s to 200s over 120s. And I'm looking at her like, ma'am, please, I'm not the enemy. And so I told her, I made an agreement with her. I said, if you allow me to say it's go time, I won't deliver you today. But when I tell you it's go time, I need you to believe me. So I tried to create a partnership with her. She spoke very harshly to my maternal fetal medicine consultant who came in to talk to her because she thought she was trying to use scare tactics. We informed her of everything. Ultimately, she delivered prematurely. The baby was fine. But I want to tell you guys, that took a lot out of me. Because when I told her I'm ready to do your C-section, she said, wait, I don't want to get it until my family gets here. And I was like, I'm your family. Let's go. But there's a lot of things that we deal with that kind of affects us as providers. As I said, I need to move on. We do know that 80% of our pregnancy-related conditions are preventable. That statistic is exactly the same in the state of Indiana. We also know that there were 69.9 deaths per 100,000 live births in Black women nationally. And we have about 44 of those that we can equate. Some of this data is a little older. They're still, the CDC puts their data out a little delayed in Indiana, a little less. But I just want you guys to know, we only account for 13.4% of the population, but we account for double that of the maternal deaths. So all these statistics are telling us that we have to do something about this. It is now at the level of an epidemic. The CDC put out this great graph, and it's kind of far away, I'm so sorry, but it calculates from 2018 to 2021. And if you can't see anything else, the big, large spike on the purple line is actually non-Hispanic Black women. And if you look at all the other lines, it really makes you worried because not only are we increasing, but we're also almost double that of the other maternal deaths. I want our patients to know that they're safe when they come in for pregnancy, and not safe because they're coming to me because I'm a Black OBGYN, but because we have collected enough data and information to say that we all know how to take good care of our patients. But the statistics don't agree. We definitely do need to do more so that we can get a better understanding of how to care for these women. This next slide actually compares us with, wow, that's small. Okay, I'm sorry. This looks really good on a computer screen. The far end is, I think, the Netherlands, and we go all the way up, France, Japan, Switzerland, Canada. The three turquoisey color ones are the United States. The first line is U.S. Hispanic women. The second line is U.S. white women. The third line is the United States together, that third turquoise line. And look where the U.S. Black women stand. It tells us that on the world stage, we are doing a horrible job of caring for that one particular group of women, and we have to do better. I don't always want my patients to come in with that fear, but it plays in my head. One of my really good friends lost a patient 2 days ago. And the hardest thing for her, and I say this in empathy with her, is that she's a Black doctor and she was caring for a Black woman. And she said, I did everything and I still couldn't save her. And I think that feeling, it resonates. My friend happened to be an African-American doctor, but I know that her white counterparts in the room had that same heaviness. We know that every time we have a complicated delivery, every single time, in your heart, you're like, I gotta do everything I can. I gotta be thinking twice as much. At one point, there were 25 doctors in this woman's room, and they still couldn't save her. And so, the body of evidence that we have, and honestly, it was a catastrophic event. Like, this woman had I don't want to talk too medical, but she had a blood clot that kind of went up her entire inferior vena cava, like her big vein in her body. Catastrophic. It would be impossible for anybody to survive that. They don't know how she developed it. But I have a couple of theories as to why I think maybe this is something that happened. But we have to do all the research and all the work, and the funding is not always there, but we have to find ways to do it anyway. So the first thing I want to kind of speak a little more about is the disrespect. It isn't always intentional. I'm going to say that again. It isn't always intentional. Sometimes the disrespect is merely perceived. The person comes into the room. I know y'all watch these Crest commercials, because, like, be the first one to smile. You never know what just bringing a gentle, like, you know, show your teeth, thank her for coming, would do to someone when you walk into the room. Because they see you, you see them. If everybody frowning, we all gonna be frowning, you know. But if you smile, thank you so much for coming today. How can I help you? We learn in medical school, limit your open-ended questions, meaning how are you? What is this? Is that? Are you okay? Is this fine? Don't ask questions that let the patient expound. Well, I have found that that's the worst possible education that you can get. You have to give patients a chance to, like, get whatever's on their chest off. Like I said, we'll talk more about that later. But the first point of disrespect is realizing that you may not even have intended it for the patient to have received it. So the discussion I want to have about that is with microaggressions. And I know we've done a lot of diversity, equity, inclusion conversations, and people have explained microaggressions until they're like blue or black in the face. But it really is, it could be a simple statement, an incident. It could be something that was indirectly perceived, and most importantly, unintentional. It could be subtle, like you just have no idea how someone can interact. And so when you're going into these rooms and the patient perceives that perhaps you have already offended her, all you did was not smile because you got spinach in your teeth from lunch, and she didn't understand that that was why maybe you didn't have a big grin on your face and we're happy to see her. One of the things that I do hear from my marginalized group, they never say my name right. They always mispronounce my name. Or worse yet, well, can I call you such and such? Well, no, my mother named me fill in the blank, so I want you to call me fill in the blank. And that seems like an innocent thing. And trust me, I have stood outside of rooms practicing names before, okay? Abdullah-Kala-Sensitim. Okay, Abdullah-Kala-Sensitim. Walk in, butcher it. And I'm like, ma'am, I'm so sorry. Can you please tell me how to say your name correctly because I want to respect you in that way. So I brought a couple names, and I don't know if y'all can read them, that I have encountered in my practice. I've actually met 3 of these patients. I have not met one of them. But would anyone like to take a guess at that first name? Can you see it there? I don't know if you can actually see it. Have you seen that name before ever? I know, right? You go to AB, right? It's the first thing you think, obesity. And I asked her, like, well, when your mom wrote it down, she said she was so proud of herself, and I immediately left it alone. I said, okay, obesity, I get it. The first, hey, got them letters in, she capitalizes it. Even when she signs, it's all capitalized. But you just give her that respect. The next one I think I've probably seen more on the internet. Anybody? The next one? LaDasha, yeah. I don't know. It makes sense to her, so I guess I'm gonna roll with it, right? Right. Mm-hmm. The next one, I met this patient and I tried really hard. Do not say real, because it is obviously not real, but I tried really hard. I was outside of the room, I was showing it to people. I was like, guys, come on, help me. Like, we gotta get this right. I go in, and any guesses? Ariel, like the Little Mermaid. Yeah, I know. You said, I thought the same thing. I said, well, obviously. Like, how did I miss that? And then the last one is a young lady, cute, adorable, love her. I tried to give her every name but Arciana. I gave her so many other names. And she was like, it's close, Dr. Hawkins, but that's not it. I said, okay, I tried. But just, something that simple, like coming in and saying, hey, I want to say your name correctly, and then giving them that respect. Complimenting someone on how well they speak. You're like, well, I was giving her a compliment. What did you assume that she would sound like? Seems like an innocent thing, but it's definitely perceived as a hurt, an attack. And so you have to be mindful of those things. Making assumptions about someone. Trust me, everybody that comes to my office has a husband. Oh, is this your husband here today with you? Thank you. I don't make any assumptions about boyfriends, fiancés, none of that. This is your husband until you tell me otherwise. I don't care if you got a ring on. I don't care if you got 10 rings on. This is your husband? Okay, great. And it isn't meant to assume that everyone has to be married, but it's definitely meant to not offend someone if they aren't. I don't want to come in and tell you this is your boyfriend because I didn't see a ring on your finger when you're pregnant and your fingers are swollen and this is your husband. So I try and err on the side of being, I include instead of exclude. I've had this happen at work to me. One of my colleagues walked up, touched my hair, and said, oh, your hair looks like a wide receiver's hair in the NFL. After he picked the rest of his teeth up and he got up off the floor, I explained to him that you don't touch a black woman's hair, and definitely don't comment on it with your hair looks like a wide receiver's hair. I tried to educate him. He'd been practicing longer than me. But sometimes you just have to put yourself in that space, and you have to make sure your colleagues understand how and what other women feel like. Asking people how long their hair takes. Do you wash your hair often? These are just not questions that need to be asked. Not that it isn't informative, it's probably just not the best time to do it. If you want to make her your friend and, friend her on Instagram, fine. That's a great time for you guys to talk about that. But during her visit is probably not an ideal time. Wanting patients to know that there isn't a judgment inside this room. I am here to take care of you to the best of my ability, and you have to be forward-facing with that, because they catch it and they see it in a minute, and they will call you out on it every time. And so, like I said, these things can be subtle. They cannot be intentional. They can be, well, how does she get offended because she did? And that's what's important. The next next slide, I kind of did a deep dive looking through like NIH data, so like kind of wanting a more broad spectrum, collecting broad spectrum data. This study was published in 2020. During the time, they had 3 states, 25 hospitals. So this wasn't like 1 or 2 women that they had kind of like polled and found out that they felt marginalized. But racialized pregnancy stigma, be it you're single, be it you have too many kids and you keep having more. I am also guilty, and I have to check myself every time I think it. I have a lady the other day, she has been pregnant 6 times. I've delivered 5 of her children. She came in because she had missed a period, and before I could even think it, I said, another one? I said, oh, Lord, bite my tongue. It is absolutely her reproductive right if she wants to have 20 kids. But you have to catch that. You have to recognize in yourself, that's bias in me. I got 1 and I can't take care of them. I don't know how she's trying to take care of 7 or 10, but it's not for me to say. I'm here to take care of her. That's my only job. So I'm talking, but I'm also pointing, like fingers at us, fingers at me. But we are recognizing that women are getting poor infant and maternal outcomes. We are not giving our moms a chance to be able to say the things that need to be said, even in the most precious space in their exam room. We also have a reduction in access to quality health care. I'm going to say quality health care many times because when I say quality, I mean the kind of health care that you expect to receive, the kind of health care that you want your family to receive. That's what I mean when I say quality. Not because I work at the indigent hospital or because I work in the free clinic and this is the best we can do. That's not quality health care. But unfortunately, oftentimes that is what we're getting handed to us and expected for that to be the best. We're also seeing poor psychological effects. And later on, I'll talk a little bit about how overdose deaths are rising in African American women, which that had not been something that we had seen before, but we're seeing it now. The next piece of that quote I want to talk about is unprotected. Now that doesn't mean that there is someone out there, a militia, looking for black moms and trying to harm them. That isn't what it is. It's just saying that we, as healthcare providers, aren't doing everything in our power to engage, to identify, and to correct whatever the mistakes that have been made in the past. And so the concept that I want to introduce to you today is the weathering hypothesis. Has anyone heard of the weathering hypothesis before? The first time I'd heard it was probably about 7 years ago, and when she said it, I had a complete aha moment. So I'll read that for you. It's the chronic exposure to social and economic disadvantage that leads to an accelerated decline in physical health. Like what happens to a leather belt? It gets weathered. It gets torn down to the point where it what? Breaks. And this is perhaps to explain some of the disparities that have existed amongst black women. Generations of having to deal with not having a father in the home, generations of not having a partner in the home, generations of living with the stress of having to care for children without any assistance, or better yet, and this is my favorite, some assistance, but not enough that you need to really take care of your children. The way the government is set up, they're trying to protect as well as extend. And so, but the lack of both kind of puts you in a tug of war. And so the moms who really need the help are oftentimes not the moms who get it. So wanting to make sure that we think about that, because I do think this is crucial to explain why some women are dealing with higher rates. We're finding that we're seeing earlier and an inappropriate decline in health. Like a woman who comes in 25, 32, and should be otherwise healthy, maybe she doesn't have an uncomplicated pregnancy because perhaps her weathered experience has made her closer to like a 40 or 45-year-old woman. And we know that they have a whole different set of complications and issues that we sort of manage differently. We know that there is a higher differential between black women and their peers, and we're certainly seeing women, like myself, postpone childbearing after they get their career started. So guess what? I wasn't 27 when I decided to have a baby. I was 32. And in doing that, I then increased my rates. And like I said, I was an obese black woman. I'm not going to sugarcoat it. My doctor kept looking at the scale. I gained 6 to 10 pounds every visit. And I said, I think the scale's broken in the office. Okay, maybe it wasn't broken. Maybe it was me. I liked juice when I was pregnant. I don't know why. However, I think the real opportunity here is reversing the experience of weathering, but I'm not going to say that you or I are going to do it. I think this is going to be a generational problem that we created, and it's going to take generations to repair it. But it's time for us to dig in now to start doing that work. So the roles that we all play in reducing Black maternal health, I think it starts with every single patient as they walk in the room. You have to be comfortable talking to your healthcare provider. If you walk in the room and you are uncomfortable, and I want you guys to take this to the people that you know, that is not the right healthcare provider for you. Find someone who you feel comfortable with, or at worst case scenario, give them a second chance. Maybe they were having an off day, you were having an off day, and you guys need to try it again. But if you're not safe to talk, you're never gonna get all your concerns met. Next, we wanna know and seek immediate care when you're having medical urgent needs. So, like I said, being on the MMRC, as we call it, we get to find out about all these deaths. One of them is sharp abdominal pain. In early pregnancy, if you have sharp pain, you come in, you get an ultrasound. Maybe not always an ultrasound, but definitely evaluated. So women that don't know that I'm having severe pain, I'm just gonna take a nap and lie down. In recent years, we've had multiple deaths from hemorrhage due to ectopic pregnancy. Had they maybe sought care first before taking that nap, one lady, she was talking on the phone to her mom. She said, oh, my stomach's hurting, I'm gonna take some Tylenol and take a nap. 5 hours later, her mom finds her in her bed dead. Like, it's too much. Like, we have to figure out where the piece is, because her mom should have said, wait, you're hurting that bad? No, why don't you call the doctor or go in and get checked? Several of these women didn't even have an opportunity to seek care. They were so early in their pregnancies. But we do have to make sure families are aware of that. Also, share any recent medical history. For example, our hospital system, I don't know if yours is like this, but ours is like this. We have about 17 medical records, and none of them speak to each other. We have an outpatient record, we have an inpatient record, we have labs, we have imaging, there's so many different places to get data. So when my patient comes and sits in front of me, if she's been 12 places, I may have no idea. You have to be able to share that with your doctor. Hey, I found such and such, or I went to X doctor and they told me, this, and, I was also told that. That way we're on the same page. I'm putting that in your chart. It becomes a part of your consolidated medical record. And that's not just true for patients, it's also true for families. Moms may not always remember, we have placenta brain. So you just want to bring that information. And next, I think in 2019, I don't know if this carried through since COVID wrecked the world, but I think in the state of Indiana, we were trying to increase resources so that doulas could be covered even by Medicaid. That just gives you a person in the room who can help advocate for you. Now, I am an OBGYN, and I love a good doula, but the doula is there to support the mom, not to support the doctor. I love it when they help me decide when to turn up the Pitocin or not. However, it's a great person to have available to you. Some people can afford it, and that's great, but it should be available for everyone. As far as the healthcare providers, and this is kind of the lane that we all sit in, I feel like we gotta ask real questions and then seek to get an understanding. I have a social worker that is in my office 1 day a week, and she has made a tremendous difference in my ability to get patient resources. I used to think it was me. They tell me all this stuff, and now I'm carrying this burden. I'm like, do I need to go on my bank account and get this lady food for the week? No, there are resources available, but you have to be able to access them, and we don't always have that information. Reminding patients what those urgent concerns are. Like, if you're having the following, you call a doctor, or better yet, go to an emergency room or a hospital that does maternal care. And the reason I say that is because now we have all these obstetric deserts, and some of these people are unfamiliar with how to take care of a mom who's 10 days postpartum with severe range blood pressures. So it's best to go there, but get somewhere, talk to someone. And then managing chronic medical conditions. Obesity is probably the biggest one. I left it off here, probably because I feel a little bit of hypocrisy when I talk about it, but obesity, hypertension, diabetes, getting those under the best control possible before you're getting pregnant, and that's what we should be telling our patients. Recognizing and eliminating all your unconscious bias. Like I said about the lady earlier. Baby number 7, I'm like, but why? That's my unconscious bias, because I can't imagine taking care of 6 more of my little one. He costs me way too much money. But for her, it's what she wants. That's her model or image of her family. So I can't change that. What I have to be able to do is support that for her. Responding to your patient's concerns. Remember going back to those open-ended questions? Be prepared to have at least one open-ended question. Try not to make it the first thing you do, because I have seen an appointment get derailed with an open-ended question. 20 minutes later, she's telling me about how her ex-husband and all this, and I'm like, wait a minute. What were you here for again? Like, I completely forgot. So maybe make it at the end of the conversation, but give them a chance to ask that. And then last but certainly not least, making sure that we're providing that quality and respectful care, the kind of care you expect. The next kind of rung is our hospitals and our healthcare systems. This isn't something that we can fix, unfortunately, but we do know that we are creating more and more deserts by removing maternity care in communities. We shouldn't be looking for ways to close hospitals. We should be looking for ways to keep them open and accessible. Moms shouldn't be driving 2 hours to come see me. I had a lady the other day, she drove 2 hours for a GYN consultation to come see me because she needs a hysterectomy. And you know the reason her why? I did not trust the doctors in my community. I'm like, you went to every doctor in your community? She was like, no, Dr. Hawkins, but I went to 2. I wasn't happy, and I heard about you. She drove 2 hours. That shouldn't be the case. No one should have to be forced to make that sort of decision. So as healthcare systems, we need to oh no, that's a later one. We need to identify and recognize the bias that exists in our systems. We do need to increase moms' access to maternal and mental health care in the same space. Why do I have to go to this hospital to get my pregnancy care and that hospital to get my substance use disorder care? We need to find ways to integrate all this, because if we make it easier for moms, it kind of alleviates some of their excuses. Standardizing how we care for patients. There's an article I'm going to talk about later that says they did everything, standardized how moms were given postpartum pain management, and still there was a disparity, a racial disparity. Continuing to improve how we deliver that ding, 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 quality health care, as well as training non-obstetric providers, so like our PAs, our NPs, because our nurse practitioners are slowly taking over the world, as well as our primary care providers, to help moms take better care of themselves pre-pregnancy, as well as, please don't shoot the messenger, making sure we keep access to reproductive health care options for our patients, because that is very important. I don't think we understand the gravity of it, but it's only going to get worse. The less access women have, the more women get pregnant, the worse the outcomes will be. And then last but certainly not least, I want to blame the government for everything if I can. So state and federal government, they're just not doing everything they can. It's kind of like, you know, giving me a rope to pull myself up, but making sure the rope's about that far away from where I need it to be because I can't reach it. Well, we're offering you help, but I need more. Creating funding for research. We have to be doing research on Black maternal health. Why are we not? Why is it not in every sphere, every community that exists? Because there hasn't been proof that it's going to benefit anyone. But until you do it, you don't see that proof. Continuing to review the causes of the preventable diseases and what we could do to improve them. Probably in the last, I think, 5 years or so, we started recommending that certain moms get a baby aspirin a day. I have set, I cannot tell you how many at this point hours, trying to convince these moms that I know your last 10 pregnancies you didn't need a baby aspirin. But mom, this time you're 36 years old, you're obese, please take a baby aspirin. Then they went and increased to 2 baby aspirin. No one wants to take 1. They're definitely not going to take 2. But this is the conversation. And I take that time in those rooms because I'm maybe the only voice they're going to hear that they might listen to, because 3 other people have told them to take it, and they're just not listening to any of us. So what we have to do is say, okay, put myself in her mind. She just needs to understand it better. So I'm going to take the time I can. I'm going to give her the information that I can. Now, if I can keep all my patients off of Google and TikTok, let me tell you, My job will be so much easier. But they're getting information from somewhere. They might as well be getting it from you. And last but certainly not least is identifying all these social determinants of health, unstable housing, transportation. We're still dealing with intimate partner violence because we aren't teaching our girls in middle and high school it's not okay if he talks to you like that. It's not okay if he puts his hands on you. This is something we should always be talking about. Certain people, certain individuals, certain communities, certain organizations are doing it, but we have to disseminate this information. And I don't want to say it's one way, because intimate partner violence could be either direction, but we have to communicate about that. And these are the things that I think our state and local government owe us to be able to improve and help get our maternal death rates down. I'm going to talk quickly. First, I need to drink a water. I'm going to talk quickly about maternal mental health. Like I said, one of the problems is it's in siloed. Most people have to go multiple places to get access to the care. We know that it affects 1 in 7 people, and I want to make sure I stop here and say people because we do need to include the people who do not identify as women when they come in to give birth. They own this space as well, and we have to make them comfortable here. But 1 in 7 people giving birth are affected by some sort of mental health disorder. I listed a few here, but I did leave off some of the bigger ones. Bipolar disorder, schizophrenia. Depression is a large one because we are oftentimes seeing depression lead to suicide or suicidal attempts. Moms are just having a difficult time managing, and certainly substance use disorder is on the rise. And we all know that the government could do so many more things to help maybe just do fentanyl testing on drugs. Like sometimes it's as simple as that. Maybe had she known there was a dose of fentanyl in it, she would not have chosen to take that hit. Next, strongly, and remembering that how a mom perceives her care does have a lot to do with her mental health. We'll talk about a celebrity later, but if you aren't treating the whole person, you're not taking excellent care of her. We know that in 2020, and this is national data, 74% of maternal deaths were related to overdose or suicide, and that's all related back to our maternal health rates. And then we're seeing a climb. Black women who are dying of overdose, there's an increase in that rate in the Black population. Listen, we already are doing really well at dying from other reasons. We don't need any new reasons to start causing Black women to leave here. But we have seen some improvement with extending Medicaid for 12 months because moms are able to get the care that they so richly need. What are the things we need to do? Universal screening, the 5 Ps, everybody knows them. First one is, okay, I'll give it to you, partner. The second one is peers. The next one is no, the second one is not partner. First one is not partner. Parent, peers, partner, past. Have you in the past pregnancy or in the past used drugs? And then third but not least, in this pregnancy, have you used them? So it's parents, have your parents used drugs? Peers, do your peers use drugs? Partner, does your partner use drugs? Past, in the past or in a previous pregnancy, have you used drugs? And then the last P, in this pregnancy, have you used drugs? Screening patients with just those questions, something that simple, can give you an opportunity to have a door open where you can maybe get them the help that they need. And then we do opt-out urine drug screenings. All pregnant women know you're coming in the office, you're leaving a urine sample. While we're doing that, we tell them. So we offer drug screens to all our moms. If you don't want us to, tell us, because it's not right for someone to do something to you that you didn't approve of, but it does give you information about them, because a lot of people forget that they were using drugs 2 weeks ago, but it gives us that door open to have that conversation. One of the ways that we can also do it is increase the mental health providers. Peer coaching is a great one. CHAMPS is a program that's initiated at IU, and it isn't for patients, it's for us providers. You call them and they can help direct to you where you go to find someone to talk to get the patients the care that they need. Because I'm not an expert in substance use disorder, but if I have patient dealing with it, then that has to make me become an expert. Utilizing the resources that we have for suicide prevention as well as intimate partner violence. And then there has been some conversation about extending the 1-year extension to 3 years, because the relapse rates are very high in that first year, but they don't go down drastically for the next 3 years. So just finding new ways to try and treat moms. How am I doing on time? Because I know people like lunch. Okay, I'll move a little quicker. Celebrity cases kind of hit us hard, right? I'll talk a little about Sabrina Williams. She's an elite athlete, #1 tennis player in the world. She developed a pulmonary embolism. She was on her way way to an Oscar party. I love her life, right? And so shortness of breath took her to the hospital. Now she's pregnant. I'm sure they took all the precautions in her pregnancy. She ends up needing an emergency C-section. She's laying on the table. While she's laying on the table, her baby's in her husband's arms. She says, I can't breathe. Her vital signs change. The doctors immediately recognize that she gets the care she needed, but the rest of her hospital course was affected by it. She coughed so much because of the irritation. Her incision opened. She had to get multiple incisions. Like, not saying that we could have protected or fixed it, but acknowledging the fact that it's happening, and it's happening to our women taking the best possible care of their bodies. Allison Felix, she's an Olympic athlete. Okay, thank you. Also, similar issues. The sad case is the case of Tori Bowie, who was an Olympic athlete who had bipolar disorder, was untreated. She wasn't seeking care, and as a result of that, her and her baby both died in her home. We don't really want to know, blame, I think is the right word, her for not seeking care, but there should have been someone that she could have sought to talk about what was going on. The last and final concept is neglect. I talked about racial disparities in pain management earlier. They looked at a group of individuals and who gave the patients their pain score. The African American women had higher pain scores. Who gave the actual pain medicines. They gave more medicines to the non-Hispanic white women, and then who wrote prescriptions for those medicines. It was a much lower rate of prescriptions written for our African American women. And this is among attendings, APPs, residents. There wasn't a separation, but we saw that Black women were getting less. And there was a tiny bias to it because it was women that were married, women that were non-obese. You saw the little signs of the disparities. We also find that there is a lower access to quality care in certain ethnic racial groups. And there isn't a difference between age and income. We're just finding that, and this is back in 2003, that patients aren't getting the care that they so richly deserve. I'm going to skip to my last slide because this basically says more of the same. But when I talk about solutions, I found the most complicated diagram I could find because that's what it's going to be. We're going to have to stretch ourselves as patient providers and staff. Hospital systems are going to have to find a way to integrate themselves. We have to keep the patient and their family at the center of our solutions, but all of these things are going to create, I think, an opportunity for us to find real answers. Last but certainly not least, this is my troublemaker, and thank you so much for your time. Now, I'm holding up lunch, but does anybody have any questions? I didn't think so. Thank you guys so much. Y'all have a great day.